Okay, so I won't be showing all the slides, but I'll do a little bit of skipping, but not skipping. I won't go back. I'll just go forward. One of the drivers behind systematic review and meta-analysis is simply the sheer quantity of new knowledge being produced, and a sense of how difficult it is to make sense of it. And one of the complaints here, that it's in widely dispersed publications, what is something that's kind of less important now, as we can do searches and draw in information from various sources. But still, the issue of quantity is an important driver, and it isn't just quantity, of course, it's also quality. One of the things I do when I'm training people to do coding is I give them some articles from really good journals that have some serious flaws, for example, in the analysis or in some other aspect. And they often are reluctant to actually say what they see, because they think, well, it's in the New England Journal, it must be okay. And so actually what that has led to is the idea of blinding coders as to the authors and the journal, and sometimes the findings, because there is a tendency to think, oh, this must not be what I'm seeing. They must have done it correctly. Okay, we also know that another issue is, as we've all been enjoined to think about evidence-based practice, and that claim is everything that people are doing these days, it's a pretty widespread claim, that means that we have to evaluate the quality of the evidence and be able to discriminate between evidence that's really very imprecise, not based on very reliable studies, versus evidence that is more solid. Let me just, I sort of like this one, a definition of what it is that science involves. And this says squarely that assimilating new the material, bringing together material and making sense of it in as unbiased a way as possible, is science. Now, when I was coming up for tenure and promotion, one of the people on my kind of pre-review committee said, it's really awkward that you have these articles that have these silly titles. Do you have to call them meta-analysis? I mean, it was a kind of, haven't you done any of your own science? And unfortunately, I've had a mix of contributing primary studies to the assimilation science, but that's how new meta-analysis sort of is, and how much skepticism it was kind of greeted with by some. Again, I guess it's too late to change the titles of your articles, but in the future, don't give them such silly names. Okay. So here's some terms and definitions. I never think that old narrative style reviews are necessarily a bad thing. If you think about a textbook, very often you have broad summing up of the literature. It can be very intelligent, very insightful, but it can also be very biased. And so the idea of improving the review article came both from mathematically oriented people who were trying to figure out how it is it that you put together 4 corn plot studies, and what should you say about their overall effect. But it also comes from people looking at all of the other aspects of reviews and saying there's a lot of room for bias here. maybe your assimilation, your techniques for combining the outcomes are pretty good, but if you don't have a really good sampling of the outcomes, like you have all the positive studies and you haven't bothered to look for the negative ones, you don't have much. So systematic review is kind of the underpinning of a meta-analysis. So everything about this definition is sort of is about being systematic. There is a question that's stated in advance or a hypothesis. There are methods that are transparent and can be replicated and don't look to be biased. And there's some attention to the methodologic quality of these studies. And they're analyzed in a way that doesn't also create more bias. But I like this definition the most because it basically sums up every step. And as I've worked in meta-analysis and systematic reviews over this long span of my career, the standards have only improved. So, we got to think about how to assess study quality, and we developed coding so that there was not so much bias. But only in the last 10 years have we really looked at the searches and said, you know what? People like us should not be doing the searches. We don't do a good job of it. It's very difficult to do a good search, and we actually need to have the partnership of a trained librarian. So as time has passed, we have higher and higher standards. So notice that the meta-analysis is a subset of a systematic review, again, because a meta-analysis without all the systematic part wouldn't mean much, no matter how elegant the statistics that were used. Okay? So it's a type of systematic review. But you can do systematic reviews, as I'll show in a few minutes, that are not necessarily meta-analyses. So we want to both stay away from the pitfalls of sort of lazy what we call vote counting methods, but we also don't have to use meta-analysis sometimes to create a review of importance or interest, depending on what we already know in the field. So this is a way of looking at the different levels of critical analysis that can be used in a systematic review, and I'll return to this a little bit later when we talk about aims. Oops, yeah. Okay. So there's another one-pager that's right next to the course learning objectives, and it's the, just pull this out. It compares a primary study, the methods of a primary study, to a systematic review. So steps in primary research versus systematic review. Okay? And this has a pretty simple premise, which is that they're just alike with some difference in terms. So if you look at the first two steps in a primary research study, and one of them is on the slide, identify specific gaps in knowledge that a new study would fill. That's exactly the same step that we have for a systematic review, except that it's what gap in knowledge will the review fulfill. And so on down this list, which is intended to show you how what the matchup is on slightly different terms, but in general that we're going through exactly the same steps as we would do for a primary study. Okay. In the debate over whether meta-analysis is better than other sorts of reviewing, we've had to think hard about what are the strengths and limitations of a meta-analysis. And here I'm kind of focusing on the strengths, which is that the kinds of questions that a meta-analysis can answer, having to do with how similar the studies actually are, the findings for these studies, and looking at the best overall estimate of an effect. This is at the level of meta-analysis. Giving us data on how precise and robust, meaning sort of confidence interval size, is this estimate, and then can we explain variation or dissimilarities across the studies, okay? And so the one thing that meta-analysis absolutely does for us is it gives us more power to look at the effects in a set of studies, okay? All right, so here's an actual meta-analysis forest plot. Has everybody seen one of these? Yeah, they're kind of now part of our sense of the literature. And there is a one-pager that blows up this, this view of a streptokinase therapy for patients with acute myocardial infarction or heart attack. And so who can tell me what do the rows mean? What do they stand for in a forest plot?
Study?
Yeah, a study. So we have here actually 33 studies, okay? They're presented in chronological order, which is one convention for lining up studies. So we have the
first in numbers.
Pardon?
Huge difference in sample size.
Ah, yes. So if I asked you to decide whether this was a therapy that you wanted to use with your patients, and I told you that you should base this on how many studies were significant, have significant p-values of less than 0.05, what would you be looking for on the forest plot?
If you want to know if it's significant or not, you might have the confidence interval crossing the line.
Okay, so the point estimate is in this particular forest plot, this is not a weighted meta-analysis, and so every study has the same size point estimate, but they don't have the same size confidence interval. That's that horizontal line around them, right? These are odds ratios, and they have done a good turn and used the standard of favors that treatment is labeled and favors the controls is labeled, so we don't have to wonder which way are we looking. And so how many significant, statistically significant findings do we have in this list of 33 studies?
5.
The very, very bottom one doesn't count because that's the total. But
4, 5. I counted 5.
2, 3. The line, the horizontal line can't cross that vertical line that stands for 1. It's actually 3. But this could cause you to say, well, forget this therapy, right? Because we have all these not significant studies.
A quick question. So we only conduct meta-analysis in intervention studies?
Ah, good. No, not at all. And so I'll be talking about prevalence studies, diagnostic test studies, economic evaluations, qualitative studies, not meta-analysis,
So
but
this sample is on intervention.
this happens to be intervention because the Cochrane collaboration has done so much in that area, okay? Is everybody familiar with the Cochrane collaboration? No? Okay, I'll say a little bit more about it then when we talk about the history. Yes?
The sample size matters. I mean,
That's an issue, isn't it?
there's a huge difference between sample sizes.
And what happens to the horizontal line when you have a large or small sample size? In general, yeah, not small, a small sample size, large confidence interval. Okay, so you would expect early on that there are smaller studies, and in fact, that's what happens here, and they have huge confidence intervals, right? So that's part of the problem of relying on p-values, that you're likely to make the wrong conclusion. And you know that sort of kiss of death for any action? Findings are mixed. Findings are mixed. Well, that means that some were statistically significant and some weren't, at least in sort of old style of talking about things. And, well, I guess we better do another trial. Well, the next slide shows you sort of what happens when we see what's called a cumulative meta-analysis. This is the same data. And so study number 1 is portrayed as having, this wide confidence interval. The next line represents a meta-analysis of study number 1 plus study number 2. And then the third line plus study number 3. So this is often given, this kind of example is often shown for meta-analysis that sort of asks the question, when would you have stopped spending money on new trials and started treating patients? And the answer almost always is a lot earlier, because typically a new therapy has smaller studies with wide confidence intervals. But look what happened. I mean, all of those toward the end, that's a big investment.
What is the order?
Chronological order.
Chronological, okay.
So that's key. So as we gain more studies over time and did a meta-analysis of all of those conducted to date, how soon did we get to the kind of precision that would have made you go forward, or made the National Institutes of Health say, no more new studies? So that's one of the functions of the cumulative meta-analysis, and actually what would be considered the ideal for a discussion section. Mostly, I mean, you don't see it, but it's really, what does your study add, and where are we now in the science? And there'd be, and again, the dreams of many people who do systematic reviews and meta-analyses, there'd be a little forest plot.
So, how is this method different from the one before? Because all of these are significant and the previous are not, but are the same studies?
They're the same studies, but what's different is that as soon as you have row number, let's say 3, it is actually the meta-analysis of rows 1, 2, and 3. So
Okay.
every row is a meta-analysis of everything to date.
Okay.
Yeah, instead of being just one more study. Yeah. Medicine really came to the conclusion that evidence and evidence base is really important as a fundamental foundation for practice. But let's look at the state of reviews in leading medical journals. This was only in the mid-1980s, using very simple systematic review kind of criteria. This was done by Cindy Mulrow in San Antonio. She only looked at medical journals that had circulations of over 50,000. And she was looking at review articles. And just some important, look at all the no's. Basically, no's are bad. And some no's are virtually all studies. So no stated inclusion criteria. We don't really know what kind of studies they included or were looking for. Was there any assessment of study quality? We see not very often. Let's look at the one, all the yeses for were relevant findings summarized. You know, despite their inattention to being systematic, many of the reviews went ahead with the representation of conclusions and findings. Unclear is really interesting. So they couldn't tell whether they had summarized the findings or not. So things were not ideal out there in medical journal land at that time. So just briefly, meta-analysis goes back, actually before this time, but certainly around the turn of the last century. We see familiar names from biostatistics, Carl Pearson, Ronald Fisher. There's Fisher with pooling the results of corn plot studies. Very different from the ones that most of us have to deal with now, because they had one variable and everything else was constant. Then we had a social sciences, we had a lot going on in the social sciences in the sort of 1960s, in which, in this case, Rosenthal looked at hundreds of studies of the Pygmalion effect. That was something that sort of really drove my sense of possibility when I was graduating from college. And his mission was to understand why some studies were positive. That is, you tell the teacher that all of the students they have tremendous potential, even though they have very mixed records, and some teachers you don't tell. And the teachers who expect this high performance and think their students capable of it have better performance. But not all the studies had that outcome. And so he set about exploring hypotheses about what accounted for the difference. And one of the findings is that they told some of the teachers very late. So, you know, it's like February. Well, the teacher had already formed impressions of the students that weren't really able to be displaced by this positive information. That is, the information has to be available early. Okay, but rather than just sort of saying findings are mixed and maybe it could be any one of 10 things I can think of, you saw a real test of those, of his hypotheses. So we have Richard Pito. This is Jean Glass, who compared the effects of psychotherapy to no psychotherapy, concluding that 80% of the people in the therapy group showed improvement over the untreated people. And I remember doing, I'd just been funded by the National Heart, Lung, and Blood Institute for a trial of smoking cessation in pregnancy. And a little postcard arrived in the mail one day, because that's how we were communicating. And it was from some place called the Cochrane Center, and they wanted to know what were my aims. You know, they wanted to know all about the study I was now conducting, but didn't have yet findings on. And that's where the Cochrane collaboration started, with an interest in pregnancy outcomes and around that period of time. And it grew to an international collaboration that at this point is widely respected, is kind of like have franchises. You know, you turn in there's a group who say, you know what, we need a review in this area because we're experts in this area and there's nothing there. Please, somebody somewhere make a proposal to do this. And then it's conducted according to very clear standardized procedures, and they have become a go-to place for deciding whether to do something or not. I mean, because it's also not only interventions, they're branching out into other areas. But just an interesting thought about the Cochrane collaboration is they said, we do not bother with non-randomized studies. We're not going to look at quasi-experimental studies and not cluster randomized studies, just individually randomized studies. And indexing was so poor at that time in our databases that they had real difficulty finding the randomized control trials because they weren't really tagged that, and or they were, but they really weren't randomized control studies. And so they actually came to a deal with the National Library of Medicine that if they said it was a randomized study, the National Library of Medicine would tag it a randomized control study. But I mean, it was that difficult, even with this very easily, you would think, discovered standard. Campbell collaboration is kind of an offshoot of the Cochrane that deals with social work practice, criminology, and it used to have more public health topics as well, but it does kind of fill in more social science and public health areas. The Cochrane developed a public health field group, which is the group who think up what do we need to see in systematic reviews. And finally, around that same time, the U.S. Community Preventive Services Task Force was sort of born, the community guide. Now, it does not always use the best standard. It does not use the best practices of meta-analysis, I'm sorry to say. Yes?
If we base this meta-analysis on published data, we know also that the data is published more the data that are significant, that are positive results.
That's one of the biggest challenges.
So it's not data
Yes. Well, but when we look at the Cochrane standards, we'll see that they view it as a serious limitation if you have not looked for unpublished studies. And there's several things have happened that are helping us build a denominator under the trials that were begun and maybe not published, right? So when I got called to be a member of the U.S. Preventive Services Task Force, I sort of asked myself the question, I actually asked Ellen Hinman out loud, is this going to set public health back? Because I wondered how much literature we really had for a lot of the things we do in public health. But as it turned out, it's about half of the reviews they do have adequate studies and half don't. But we've made lemonade out of this by saying, well, that's the research agenda. Okay, so there are lots of these evidence hierarchies out there as we think about evidence. What's evidence? I'm going to do evidence-based practice, so which studies should I pay attention to? And what we see in almost every case is that the systematic review is at the top of the list. One, because it's more than one study, and two, because generally the methods are better. But as we'll also see, there's a group called, these acronyms are everywhere in this area, called GRADE. First of all, has anybody ever gone on guidelines.gov? One? Yes, good. Anyone else? It's a great resource because it includes medical treatment guidelines, but it also includes public health kind of guidelines. And it does not screen. It just reports. It's a warehouse, sort of. And you can do things like compare two guidelines, and you'll see, oh, let's see, what is the American Cancer Society, what are their methods for deciding about a recommendation? What about the U.S. Clinical Preventive Services Task Force? And you'll see that they're very different. That all the names of the experts that ACS brought in are listed as their main method is, oh, well, we had Dr. Whoa. So you see that there's a lot. So the idea of why can't we rely on some similarity of methods across guidelines so that we can evaluate them more easily? Because I look at these two and I think, well, they reach their conclusions on very different basis. Which one is better? So a group that has called itself GRADE, it's basically grading the level of evidence that's presented in any guideline. Okay, and so I'll say more about this. It's a very interesting. It's still pretty qualitative, but it's an interesting idea, and it's taking hold. So basically, it's can we trust these findings? How precise are they? And would it work here? So it's kind of across the types of validity, if you will. But I'm still on the history of sort of meta-analysis and systematic review. This has been an era of kind of quality improvement, I guess I would call it. Lots more research on the impact of study features. So which ones really matter? You know, blinding is really good, but does it matter? And does it make a difference in the findings? That kind of study has been going on for some time, but it's certainly important now. It has led to, and has anybody ever coded a study for systematic review? Okay. At any time, has your blood pressure risen, or have you just been incredibly frustrated by not being able to figure out whether they did this or not?
Yeah, yes, the one that we were working on, we kind of built our coding system, but then for example, we wanted to look at exercise interventions for fatigue. So then we wasn't sure if for example, if we wanted to look at exercise like physical activity, or if we will include what you said, some kind of
weightlifting or
not
no.
weightlifting, like
daily activities.
No, it's like medicine, natural medicine, like how you call, like acupuncture.
Okay. So yes. So
alternative medicine.
good. So part of that dilemma is setting the boundaries,
Yes.
and we'll sort of talk about that because many decisions are required. And the other one, the one I was sort of fishing for, is you can't figure out whether they use this method or not. Like, how did they randomize people? Let's say it's a randomized trial. Or were the study data collectors blinded? It turns out that's a really big deal. So coding a study can take hours. I mean, that's been the rate limiter of systematic review. It's just not reading those studies. It's filling out a form that says stuff that the authors didn't even talk about. But you have to read the whole article. You have to look everywhere, because maybe they talked about it in the limitation section. They didn't mention it in methods. Anyway, so reporting guidelines are directly a result of people who have had to code these things and just felt, I'm so angry at these authors for not telling us what we need to know. They're a great resource, so I'll be talking about those more. The issue of publication bias has certainly come to the fore, especially with drug studies. And so now it's getting very difficult to publish an article about a trial, even if it's not a very trial-ish, but where there is some assignment that is unbiased. They are saying, you've got to have a trial registry number or we can't accept this manuscript. So that's really finally coming online where it's being enforced by journal editors. It's going to take a while to really, till we really feel it. But we will at least be able to say, you know, there were 10 other trials registered at a time that should now have resulted in publication, and we haven't seen those, and perhaps all of those are negative. I mean, you could do various things with it, but because we've been looking at numerators, and all good public health people and other researchers in medicine know that you've got to know something about the denominator. And we've only been able to kind of estimate it before. Now we're getting better. Indexing quality I mentioned in the sense that, remember that Cochrane had to tell the National Library of Medicine which were the randomized controlled trials. We finally have reached the understanding. I used to bring our librarian in to spend a few days or weeks in a semester-long course telling people how to search. And about 10 years ago, I just said, that's ridiculous. None of I mean, every database requires, you know, different terms and different kinds of Boolean indicators, and we can't do it. We can't do a good job of it. And so there's now the idea that you probably need to involve a trained person who knows how to do searches. But the other way that it's been answered is people are now publishing studies of the precision of various combinations of keywords. So I have an example of one, how to search Medline for something. And they looked at what most of us would do. Oh, this is for reviews. So we would just pick the review thing. I mean, there's a term, right? But it turns out if you use what they call a hedge or a filter, which is a kind of preset combination of words that go beyond that, you will have a better return. Okay, so that's been one response. So you can't use a librarian, but you can use filters that kind of come off the shelf, or you can find it in various places, and that will help you do better searching. And then our colleagues at the School for Biomedical Informatics on our Health Science Center campus are going to natural language stuff. I mean, they're just bypassing all those mesh terms and everything else and just saying, no, we don't have time for this. We're just going to go in and look for combinations of words to make to identify potential studies. They always have to be confirmed by someone reading them, but that whole idea of the kind of searching we're doing right now is not something that's really sustainable. Okay, I'm also going to argue that 30 years ago I could do a review on almost anything and there wasn't a good systematic review, certainly not a meta-analysis in the literature already. That's not true anymore. And so you need that filter to look for previous reviews, and then you can look in the Cochrane to see if they have an update in process, so that's another way. But we now are starting registries for reviews because you're potentially going to put so much time into a review that has already been done is not a good thing. And so that's kind of coming. And so review registries and other sorts of guidance for particular parts of primary studies.
But in general, it can happen that you're looking in PubMed or Medline and you don't find that review. That happens.
If you do what I would do, or I would have done, which is just pick review. Like that's one of the delimiters. No. So now I know that I'm going to put this package of terms in, and I will do better. But that's only one database. And so I need a filter for each database because each one is different. And so that's where people get to the idea of let's register reviews. So you're protected against somebody who is ready to, it's out there or it's almost finished and it would scoop you. But so here are two things that I want to kind of spend a bit of time on. We've talked about standards, and there are two different types of standards I've actually talked about. So if you look to the right, the reporting standards, those are the ones that frustrated coders have put together. Has anybody heard of consort? You know that flowchart that doesn't have percentages anymore, just like has numbers? That's required by the consort guideline, which was the first one issued and the splashiest because medical journal editors, public health journal editors all lined up and said, we want this report. All the stuff should be reported if you're going to be published in our journal. Okay? So consort was kind of the start. And there's a website that I'll give you the URL for called Equator. Anybody heard of Equator? It's a fantastic treasure trove of reporting guidelines. And so it has the grand old ones like consort, what should you put in a randomized trial, but it has all kinds of other sorts of ones that people have put together. Like there's one I like, it's called Cherries. I mean, they're all acronyms that have been tortured sometimes to turn out into a word. That's written by the journal editor of internet surveys. And so it isn't the only standard you'd use, but it has lots of sort of good advice about what you should say about that unknown, the denominator. How do you do this reporting? There's one, my favorite term is one, Bayes watch, is for Bayesian statistics reporting. But it's fantastic, and I'll show you why it's good for your students, it's good for you, because they tell you what to write, and in some cases, like with consort, how to write it. Like here are two examples. No, it doesn't take a page. Just, you could do this. Okay, so reporting standards actually are not in and of themselves standards for what we would consider a quality review, because I'm going to use review now here. It's what you should report about your review, and it certainly gives you ideas about what is important and makes a difference in the quality of the study, but it's not really a quality rating per se of the study. It's a quality rating of the reporting. And so the first one was quorum, about 1999, and around the same time, Matthias Eger and epidemiology colleagues published Moose, and that was for meta-analyses of observational studies in epidemiology. Okay. Since then, PRISMA has replaced quorum, and you have a PRISMA document in your folders. And then I listed the last one not because it supplanted anything, but because it helps with the reporting of reviews of qualitative studies, something that has sort of been neglected in the heavy Cochrane randomized trials sort of movement. So there's a lot more recognition of the need to be able to synthesize in some transparent and appropriate way qualitative studies. Okay, so enhancing transparency and reporting the synthesis of qualitative research. I don't even know how to pronounce it exactly, but So these are reporting standards that are relevant to reviews. So I would definitely want to look at PRISMA as a sort of good, more all-round than it looks. You could use it for observational studies in epidemiology as well, but some specialty ones like on track. At the same time, there are now quality standards for conducting systematic reviews and meta-analyses, meaning here is a way of deciding whether I should trust this particular meta-analysis or systematic review. And right now, there are sort of multiple things out there. One of them is AmStar, and this one called Messier, would that be the pronunciation? I didn't do phonics. I was educated when phonics was out, so I'm very bad at pronouncing things or hyphenating them. You have Messier in your packet, and we're going to use it to look at the meta-analysis that Mike will be using this afternoon. Okay. And then there's something I just came across called CASP, Critical Appraisal Skills Program. And this is a nice introduction to critically appraising the literature. And it has not just systematic reviews, but it includes a variety of studies. It's a nice teaching tool and not so complex and technical as Messier, which has 80 different sort of points to look for. These are like 10. But this is a kind of neat resource. So the bottom line is, I think I'm going to kind of skip this set of slides because they're pretty easy to read on your handout. And this sort of says, how can systematic reviews help you? And the sort of upshot is they can tell you where new research needs to be done. So people looking for dissertation topics or, what should I be studying in this area will get some advice. Some of the reviews are about methods, and so, you asked, do they all have to be outcome studies? We can do systematic reviews that look at like all the measures that are used in a particular area, and then they're compared against what we think is the best standard in measurement. And so you find out that these measures are the best we know about. You can use that for your study. So lots of good ideas about methods that you can back up with actual data. Systematic reviews can really help you write the introduction to your study, mainly by pointing out the gaps. But they also help with the discussion section because all the studies are kind of lined up. And they aren't just lined up in some paragraph or set of paragraphs that are really hard to figure out. They have evidence tables. So you can really begin to look at where does your study fit. And then, I don't know about you, but for me, doing a power analysis, the tricky one always is, what is the effect size I think I can find, and then what about standard errors in that effect size? And because meta-analyses will be about reporting effect sizes, some at real cost. I mean, you have to call the author, but here's that effect size and the confidence interval or the standard error. It's just like delivered to you on a platter. And so they can be really handy for that as well. So there are lots of, so the methods of systematic review and meta-analysis can really transfer to primary studies. I make all of my students now do an evidence table just so they can write the introduction. I mean, I want to know everything that's out there, and then it's your job to synthesize it and not skip stuff that you don't understand or that seems anomalous or whatever. And so so these are really handy, even if you never do a systematic review and you're doing only primary research. It can help you a lot. In fact, journals that didn't used to accept review articles, because they're long and have started saying, oh yes, please, we'd like to have systematic reviews and meta-analyses because they're so often cited. Because when I'm writing my grant and you've told me that this is the measure of choice, I'm going to cite that. And so the field is much wider for publishing meta-analyses and systematic reviews, especially as they figured out what can be on your website or available from the first author, so they can cut down how much time they take. Okay, I said I'd skip through these. So, systematic reviews and meta-analyses are your friend. All right, let me just get out of here. So questions or comments? Come on. I'm trying to get it. I may take me a while to get out of this.
Could you tell us a little bit more about the Cochrane organization and
Oh.
what kind of... are you still involved with them? Or?
Yes, and even if I didn't want to be directly involved, they're useful because I can look for reviews there that are done on a variety of public health as well as medical interventions. They've made, it's pretty democratic. And in that sense, they've made their glossary available. Their software is now available. Their handbook is online, so you don't even have to buy it. You can just download it. And they're always sort of in the forefront on methods because they have attracted a lot of methods people. And so they produced a lot of things I think are good tools to use. Okay. Because they're international, they have helped us break out of the idea that, well, I only read English, so I'm only going to look at English language articles. They've said, you know what, you would have missed all of the St. John's wort stuff if you didn't look in the German literature, for example, because that's where it is. Or cactus therapies are in Spanish. And so they've helped people see, because of this international collaboration, they've helped people see what they never would have known about. So I think that's been a terrific aspect. They felt like maybe like a Starbucks franchise. I mean, you have to, like, you know, everything has to be done in a certain way, the Cochrane way, and you can never deal with anything that isn't a randomized controlled trial. And those days are over. They have now methods for non-randomized trials. They're doing diagnostic tests. They aren't doing prevalence, but a lot of the tools would apply. They've had to pay attention to qualitative studies. I mean, that wasn't easy. And the idea of what if your review contains qualitative and quantitative studies? Do you just ignore the qualitative? Not anymore. And so we could go to the website. I think probably some of you are, right?
This is Cochrane.org.
Yeah. Or just I just Google Cochrane.
And they have already 22.
Right.
They have already 22 colloquiums.
Oh, they've just taken on this area and done us all a favor in the way that they've pushed things. I mentioned the problem of coding, and my negative feelings about people who write articles that aren't very transparent. I did a systematic or a meta-analysis maybe a couple of years after Consort came out and started being required, and like it was half the time, because if the data collectors are or aren't blinded, there has to be a statement that says that, and it's always kind of in the same place. It's in the method. So I'm not paging through thinking maybe it'll be somewhere, because you can't check no if they don't do it unless you've looked. So that has been a tremendous improvement. And I don't always easily find stuff on the Cochrane website. So when I looked for Messier, I finally just Googled it because sometimes I find it a little difficult to navigate the website. So I had to know it was there already. But it's really sort of the granddaddy of this whole enterprise, and a great place to go if you just need to know. I wonder what we know about the effectiveness of continuing medical education. Well, they aren't the only ones who said it's not effective, but they've also looked at a whole raft of interventions, and so you can, it's a great place to find out what's been done and what we know. And then when a meta-analysis is too old, and by that it isn't just the date of publication, it's also what's been published since then, they withdraw it. Say, that isn't what we know anymore. and they'll often then say, and that group is going about the next one, which is a good signal not to do it yourself, probably. So it's one of the go-to places for both new knowledge and then for, as I say, for methods. Okay. I like to spend a little time on rationales because it does get us into the question of finding reviews. Where's the little, there. So basically, the ingredients in a rationale are pretty much what you would expect to write in a primary study with one difference. Okay, so we do want to know why the health problem is worth bothering about. That would be the kind of thing you would tell your students or write in your primary study. And in a primary study, you would also say there's something that is compelling that we need to know that we don't know. Okay, the gap in knowledge. And remember, systematic reviews can really help you establish that gap in knowledge. So we don't know the efficacy, we don't know the specificity and sensitivity, we don't know what, there also can be some, remember, qualitative sorts of gaps. But this does help remind you that various kinds of systematic reviews can be conducted. Okay. This is really important because you can't do a review if there aren't any primary studies. I mean, once in a while, it's really instructive to say, we've been doing this for a long time, we consider it a standard of practice, and we've never had any evidence that it is actually efficacious or effective. But most of the time, we would like some hint that in the last 2 years, there's been a lot of interest in this area and publications to give your reader the sense that, and especially when this is a protocol, and you're saying, we're going to do this, I want to have a good idea that there are some studies that haven't been in a previous review that you're going to look at, you will be able to look at, because otherwise you can't answer your question. And then here's the new one, which is no reviews were found that address this gap. Now, mostly we can't write that anymore because there's so many reviews. And of course, the way you would say that, you would not say it quite as absolutely as this. No reviews were found, that address this gap. You'd be a little modest in case there's something you're missing. Okay, so this is just through 2009, the sort of uptick in reviews, which is why we always have to start with, let's search for reviews to see what's out there. Because there the likelihood is that there are some. This is the article I mentioned. This was published actually in British Medical Journal, and because it's a big enough deal that this is the one that says, you know what, our combination, it's like an incantation and a witch's brew or something. Our filter or hedge is a much better way to find reviews than just clicking review, okay? And it's there for you to use. And there are other filters and so on in other areas. So this even, librarians are really getting onto this, that they can do receiver operating curves, because they're looking at what? Sensitivity and specificity, right? And in the case of the librarians in the systematic review world, there's a heavy bias toward sensitivity. They don't want to miss anything. Specificity, so you have to read a few thousand more titles and abstracts. That's nothing. So the librarian is going to be oriented to getting you sort of everything possible, and a little bit cool on how much time you might have to spend. So you have to kind of work with this person to kind of be reasonable, which means a little more specificity, please. Okay. This is just a series of questions. Oh my gosh, I'm doing my review, and then I had an alert, and I got a review came in, and it's 2 years, I just saw it now, and I wonder if I should just give up, because it's only 2014, and this was 2012, so what's the work you have to do, right? So you have to read that review, and you need to be able to critique it. I mean, was it a good review? Oh, maybe they only looked at only the published data. I wonder what's out there in what they call the gray literature. Maybe that's something I could add. So you're thinking not just, give up when you see something, but you've got to critique it. You also, in the critique, will find things almost always that you can use. Like, they have a great search strategy, at least for this. They really figured out how to code this outcome variable. And I'll be using it with citation. So you're not just dismissing them, but you're wanting to find ways that your review adds, and that and things that you would like to emulate. So we never say, give up until you've really looked at these reviews. And in fact, I have a little evidence table template for previous reviews, so you can just have them out in front of you and sort of say, well, here's how they do. Here's some critiques. Here's some good things. Oops. Okay. So one of the things about a rationale is that we know this from primary studies. It leads directly to your aims or hypotheses, right? So it's like a funnel. You know, we start here and we go, and then I read the aim and I think, oh yeah, it's a natural outcome of reading the first part. And so that's why the aims are at the end of the introduction. It's now pretty standard. And then right after that comes the methods. So it's really logically set up, and then the methods should relate to addressing that aim. Okay. You can look at this. We have. Okay. I'll be talking about aims in a minute, so I can skip these. Just to remind you, good ingredients of a rationale. And I had used this work from a student draft, but you can look at this at your leisure and sort of think about, does it have, what ingredients does it have? And is it the logical kind of coming together to preface a specific aim? And let me tell you that it doesn't have all the ingredients. All right. So questions while I change slides? Yes.
You mentioned a couple of times the unpublished literature. Can you strategy for this?
I'll say a few things about searches. And then Masir has, like, I don't know, 15 items about searches. And we'll talk about the unpublished literature, which is very important. Okay. So two things that kind of fit together here. I just want to watch our time. Okay. Okay. So one of the things we said about a systematic review that makes it systematic is we know what question you're trying to address. You have aims, you have hypotheses, okay? And they relate to not just the introduction, but what comes afterwards. The first thing that goes into a method section is, what were the eligibility criteria for the studies that you were seeking? Okay? This is where I can find out if you were looking only at published studies, or you are an impaired English-only reader like me, and you said, well, then let's just make sure that everything is in English. So there are more decisions that come with this, particularly in my field of public health, because there's so much variation. You know, I can name a particular type of intervention, and I can go out and look for that, studies that relate to it, and I'll find unbelievable variation. And so, well, I thought that criterion was enough, but now I've got to say, maybe it ought to be a little narrower. So you might have to keep adjusting, even though Masir says you have to be, you know, everything is a priori. We learn sometimes as we go. Okay, so we already sort of did this, looking at primary studies versus systematic reviews in looking at the overall methods. And so now the question is, are the aims the same? How would they differ? And so both have plenty of variation, but each has some areas in which it excels and you really can't do the other thing. So we have questions that are appropriate for primary studies, and then ones that really are appropriate for reviews only. And okay, so here's, so when you have a question like this, you know, is this a good question for a systematic review? I see some head shaking. Why?
I think it is not specific.
Ah.
There will be many aspects that different studies can be addressed differently.
Okay. So one critique of that question is it's just really awfully broad. But is it a good thing? Is there a high likelihood that I can answer this question with a systematic review?
Well, there might not be many whole department papers about HCP.
No. I mean, why would we publish a paper about that? We just do stuff, right? So a survey would probably be better. What are you doing about? Are you recommending HPV vaccine for boys? So this might be the kind of example. You want to know what's contemporary practice, who out there is doing this, and you have to say, do those people out there publish this kind of thing? And they really don't. So that's a kind of classic one to, people say, oh, I'd like to do a systematic review on contemporary practice by emergency department. Say, well, and do people running emergency departments publish this kind of thing? No, it really would be probably better to do something else. The next one I chose just because sometimes you want to know, everything is really particular. I want to know about this program and this program that looks exactly like this on a particular outcome and all this stuff. It kind of says, it's meant to say, this isn't probably also either a good systematic review question because it doesn't seem to want to generalize. I mean, it wants everything so nailed down that probably ought to be done in a primary study. Because, I mean, one of the queasy things about reviews is you've got to be willing to combine stuff that isn't exactly the same. I mean, you're not going to get corn plots to deal with. You've got populations and, a little bit different way of doing that intervention or doing even that test. Or the dose of the drugs is actually not the same, but it's pretty close. So systematic reviews help you with the sort of generalization question. Can I go beyond this, deliver to this population in this way? How about a more general look at things? So there's both conceptual and statistical kind of armaments to help you decide. Okay. One of the things that systematic review has done is helped us address new questions about study methods. And so here's an example where K always stands for the number of studies, N is for people or units. And the issue here is, what is the odds ratio we got and the 95% confidence interval looking at non-random assignment but contemporary control, not pre-post, versus randomized studies? Is there always a difference? And so this is a very small sample of each type of study, and it was really asking the question, can we combine across these studies in our meta-analysis, or should we keep them separate? But larger scale sort of questions have been addressed this way. Does blinding data collectors make a difference in study outcomes? Turns out it does across a lot of different areas. So that's one on the better collect that issue or basis. So in this case, we've got odds ratios. The point estimates are different. But what about the confidence intervals? So they are different in the sense that it's we have a broader confidence interval for the non-randomized studies, but the randomized studies both give us a narrower confidence interval and a smaller effect size estimate. And so would you say we can go ahead and combine them or not?
It's depend of the study, whether you study what you want to study, but if you want precision, you select the random one.
So you get more precision, but it goes in a little bit counterintuitive direction. You might think, oh, non-randomized studies are going to give us a better outcome. I mean, it's biased toward finding an effect. And in this case, it really wasn't. We get something more precise and smaller, but also the smaller confidence interval. But this kind of, the ability to do this kind of work has really been made much easier with people having, they've done a huge set of reviews, or maybe we're really like a factory. We've done a lot of reviews, and maybe we can answer some interesting methodology questions, right? The one thing is these were not randomly assigned. So these studies may differ systematically in ways that we're not accounting for here. So we would be more impressed if we saw larger numbers probably in each group, and if we saw it over multiple areas. And also with a larger group, we might be able to do a meta-regression when we could hold constant some of the other variables. Okay. The critique that question about health departments in boys and HPV vaccine is certainly an issue if we think about what kind of question is ideal for a systematic review. You can see how many more definitional aspects there are in the second statement or question. Okay, and the first might be a starting point, but you've got to make a lot of decisions. And we mentioned eligibility criteria, and really eligibility criteria start with the aims. And so, anybody ever heard of PICO or PICOS? It's kind of gotten out into the sort of almost common language that we speak. And what the idea here is that an ideal question has all these elements. So what is the population? What is the intervention or the independent variable if we're not looking at intervention studies? What kind of control or comparison are we looking at? What is the outcome variable and how are we defining it? And then what study types will we include? Okay. So PICOS is the start of setting your criteria, and I'm just going to do one more thing, and then we can look at the meta-analysis that Mike has brought for us. This is, I said we talk about this. The idea is that PICOS isn't enough because you also have to tell sort of at what level of analysis are you going to try to be focused on. And the thought here is that you build the base, so everything below the level that you choose you have to do, but you could stop at, say, evaluating or even describing, let's say describing. We have been recommending that the most popular anti-drunk driving intervention is designated drivers. Okay, most of us have heard of that idea, and it's so popular it must work, right? And there are lots and lots of descriptions, but there are almost no evaluations of it, as it turns out. And so it might be actually very interesting for you to do a review that just says, let's just look to see what the evidence looks like. And you may not get above tons of studies mentioning it and hardly any that actually evaluate it. Okay, so you could stop there maybe. That might be big news to everybody. Or you could say, well, let's look at not only whether they did some kind of evaluation, but let's see how good the methods actually were. And what did they measure for the outcome? Just that people chose a designated driver? Did anybody check to see that the designated driver was inebriated when he or she left the bar? You know, these kinds of questions. So you're going to pick a standard that your reader will accept. Not probably it shouldn't just be I think this is a good study and that wasn't so good. No, you need to have a criteria against which you're evaluating the study. But that would be another possibility for a systematic review. It all depends on what we already know. And if people have done this already, then you're probably going to have to go up the line a little bit. And so meta-analysis really comes in when you summarize or synthesize. Okay. I think I'll skip showing this set of slides, but what I've done is to work from a review that is on the Agency for Healthcare Research and Quality that does all of the methods reviews for the Clinical Preventive Services Task Force. And I sort of start with the what's out there and move up this hierarchy with the questions that they asked about decision aids for people facing cancer treatment decisions, okay? And so you get an example of moving up and the idea that you may be able to stop at some level, either because you can't go on, the data aren't there for you to do this, or because that in itself is really useful to get out there. Okay. Let me just say a few things about, let's see, our break is, what time? Are we all right?
If you want to have the break right now, we can have the break right now.
Okay, okay, we can do. Should we go for a little bit? Okay, I just want to not rob us of our break, okay? Sorry, let me just, so you have this nice kind of set of questions. I'll just show this one for a moment. So they're almost always future directions questions, and that's, again, what you will often see in a systematic review, and this is why one reason you read them is to say, what should I do? And there's one kind of question that's sort of off the charts, and it's the other factors questions that sometimes make for really interesting kind of reviews, like, do study findings differ by sponsor? Certainly the drug company, non-drug company sponsorship, or maybe there's something where you might worry about gender bias, and so you code the gender of the investigative team or their discipline. So there can be other factors, sorts of questions that, for one reason or another, you think is really going to explain a difference in study findings. The last one I threw in, it's off topic because it's not on cancer decision aids, but it's also to remind us that, you want to break out of that silo thinking that we have kind of in public health and medicine, and you know, I know a lot about tobacco literature. When I started working in the alcohol field to also do preconception kind of interventions, I was really struck by, in the tobacco literature, we have a very, I think, well worked out sense of what the outcomes are, and what do you do with people who are lost to follow-up? They're considered smokers. I mean, you don't just say, oh, you know, who knows what happened to them. No, we consider that there's a bias in dropping out of the study. That's not true in the alcohol literature. And so sometimes it can be useful to sort of work in another literature where where there's an interesting contrast. So that was a real eye-opener for me, and also that there's no biologic test. And I know a lot about the discrepancy between self-report and biologic testing in tobacco, and thinking there's much more reason not to disclose in alcohol. But they don't really have much to offer except the timeline follow back. So sometimes that can be useful. But where I want to take us next is to sort of thinking about aims. So we know they're supposed to be pretty specific. Ideally, will have the PICOS elements. They'll have some sense of the level of analysis that you're shooting for. But there is a beginning that probably isn't as specific, and the question is, it needs to be more specific. So how do you make it more specific? Well, examining previous reviews can be really helpful, because that's where they can be your friend. I want to use their definition, or I hate their definition, it has a lot of problems, and mine won't be the same. But you're going to have to make decisions about these kinds of things. Content experts and intended users, you know, what are they thinking about the aim that you might have in mind? And then there's reconnaissance. Go and get some studies and see something about their variation. You know, because a librarian will want you to bring me at least one study that's what you're looking for. You know, at least give me that one. Give me this one and tell me why you like it. And I'll help you find more like it. And once in a while, I've been asked to do something like work with the Centers for Disease Control on a topic that I don't know anything about. And you have to know something about the topic. I mean, the idea that this method can be applied in some, you know, above the knowledge way is just not, you have to say, okay, we've got to have people who really know this area. Now, it can be advantaged that you don't know the area, but as long as there are people who do. Because what you can bring to it is, really? You know, in studies of sexual debut amongst adolescents, you mix boys and girls self-reports? Really? Is that a good idea? They would say, oh, well, we always do. Why don't we maybe see, there's a few studies that separate the two. Let's look at those and see if that's a good idea. So you want a little skepticism and disbelief that mixed with deep knowledge. This led actually to a wonderful, a study I really liked on sexual debut, and it basically answered the question, does sex education lead to sexual activity? You know, that very American kind of worry. And CDC decided they didn't want to have it published because even if they asked the question, they thought, although we had good results, it was protective. But they felt it was so politically sensitive that the fact that they asked the question and paid for people to answer it was some kind of admission that sex education was bad for teenagers. So it's kind of interesting. So there's a series of slides here that are about how do you think of aims? How do you come up with aims? We've said systematic reviews can really help you, but what else? And so one strategy is actually a sort of conversation with previous reviews. So there's a previous review that shows that psychoeducational preparation for surgery reduces length of stay, but included a lot of studies done before Medicare limited length of stay. So the question became, does it still limit length of stay even in the much more strict number of days that you can be in hospital? Or the previous review had a few serious flaws. So so our review could answer a question that sort of says, is this flaw a big deal? Did you get a different answer if you look at it in another way? There's a series of ideas here. It's not all the ideas in the world, but I just want to go back one. This is how to find aims. Yeah, the biggest waste of time is changing your mind partway through. Because think about that. You know, you change your mind, you really have to go back and look for all the studies, you know, kind of all over again. You got to live with your choices pretty much. I think we won't worry about these. Let's see. But they're there for you to sort of have. Okay, so I said the first thing you have to do is set criteria. And PICOS is a set of criteria, right? But now you're not done. Let me just here, put it back on a slideshow. So here are some parameters that are desirable in criteria. Having criteria that you have to read the whole article and maybe they still don't report it, that's not a good criterion. You want to have ones you can apply pretty efficiently, at least in a first pass, because remember, the librarian is trying to get you as many titles and abstracts as he or she can. And so you don't want criteria that are really hard to discern. Or at least you want to look for those only in a subset of studies. You want to get rid of the others first. So reliability and validity both sort of matter here. If I went through and applied the criteria, would another person come up with the same answers? So that would be reliability. And would we be right? Would be another question of validity. Okay. But now you're going to see, maybe you're really taking my advice, you're going to go see a librarian and you say, I have this PICOS perfect set of aims, and I even have an article for you to find more of. And damn, the librarian is going to ask you more stuff. So these are more criteria that he or she will need to do the search of your dreams. And so things like geography, only the US, high-income countries, low-income, there are lots of different choices, and you don't want to be overly broad because now it's sex education and we have very different cultures mixed in. That probably doesn't work. But not too narrow. Again, there are things going on outside the United States that are worth paying attention to. Types of publications, language. Time is a really tough one because until we had reporting guidelines that said, tell us when you conducted the study, all we really have to go on is the publication date, which could be very far off. You know, it's an old study. We never really got around to writing it up. It's 10 years ago, but it has a kind of fresh date on it. And this is the kind of criterion you want to have a rationale for. So why since 1999? Well, maybe so you're going to be expected to have something to say about that if you do limit on time. Sometimes it can be over time. So let's say you're looking at antiretroviral therapy for HIV positive people. Well, in this country, it became kind of a chronic illness with the ability to do treatment in, you know, at this time, 1992, let's say, but really now we're getting to Malawi, and maybe we should have, you know, it's like this last decade. So I mean, you could do this in a really precise way that said, I'm going to have different dates for different parts of the world because of policies adopted that are really a big deal. So, and then she's also, maybe you didn't have all the PICOS elements in it. At least our person is going to say, so, okay, it's not in the aim, but I got to have this. So this all helps you get more specific. And then I have a series of slides that you have on your PDFs that go through sort of areas of criteria that you might want to think about, and some sources of help for selecting them. And so there's a whole set of decisions that has to be made here. And so here's one kind of thought to leave you with before we go to our break, and that is that the broader the criteria, the more coding you have to do. I said, well, you know, I'm interested in HIV, sexual risk reduction education for kids in school, and it can be anything. I just want to see what's out there. You know, a motivational speaker, you know, in the assembly for 1 hour is as interesting to me as the highly intensive parent education, you know, kind of 20-session intervention. Every time I do that, which could be important, because I don't want to narrow the field, I want to really see, I'm either going to have to do some further selection, you know, describe what I got, and then select a certain core of interventions, or I'm going to have to code a lot of characteristics of those interventions so I can properly describe this minimal kind of intervention versus this parental one that's so heavy on dose. So you end up making decisions one way or another, so this has a little bit of a Goldilocks thing, you know, not too broad, not too narrow, because now you won't find anything because you had all these criteria before you would accept any intervention. So you don't find anything. This person has to spend hours and days and months coding studies that aren't really very relevant, or you kind of hit the sweet spot where this is the type of intervention that people are interested in, that administrators are likely to allow in the school or whatever, and so I'm going to focus here. You know, not that too intense, not that too unintense. So these, they're just lots and lots of decisions, and that's why you need help making them, previous reviews, experts, and so on. But you're pushed pretty soon to making them because, again, I make it after I've done a lot of study selection. I got to go back maybe And if I'm going broader, I'm going to have to go back and look at some of the ones I discarded. So you really want to think all these things through. And I worked for a long time with a very inclusive person, and he drove me crazy. I mean, it's just like, and we were always having to throw out studies that we coded. I mean, it was like our firstborn child. So, you know, I got much tougher to say, really? You know, I don't think so. But that's why you need the guidance of stakeholders. You know. Okay? Okay, we'll come back. Our break is 15 minutes. Okay. Spend a few minutes talking with your neighbor about how good is the rationale? Does it have all the ingredients in it? And how about the aim? Is it what's there from PICOS and what's missing? Okay, so rationale.
The first one, or
this is the meta-analysis. Yeah, we'll look at the checklist in a minute. Yeah, but since we're going to be looking at the methods and conclusions, why don't we just take a minute to look at the first part? Okay, so you guys decide what can you find that should be in a rationale? Is it there? And how PICOS savvy is the aim? Are you convinced that they have described a health problem that seems worthwhile to think about? Okay. And they even do that in the background, in the abstract. That's good. How about the knowledge gap? Yes. So they've defined a knowledge gap that seems important. Yeah, worth looking at. Okay. And then how about primary studies and previous reviews?
They say they search the Cochrane Central Register.
And Medline.
But we're just looking right now at the introduction. This is about previous reviews. This is our rationale now. Do they talk about previous reviews that are related to this knowledge gap in their introduction?
Yes, they mention a meta-analysis.
So they've got several that they're sort of dealing with, and so are you convinced that we hope they've represented these reviews accurately? We might really go back and look if we were going to make a decision in our hospital. But do you know what this is going to do that seems that is different from the other ones? I mean, what's going to be different about this review? And they add an ingredient, which is the guidelines for practice. You know, they're saying, you know, a lot rides on this because people are really going to be making guideline-driven decisions about which of these to use. Okay. So, what will they add? What will their review add?
I'm not sure, but they say something critically ill patient. The other does mention that, or?
So maybe they have a different population.
Sure.
But you're not absolutely sure. Okay, good.
But that's the target population, critically ill.
So it's the,
All of them.
so what Mike is saying, that's the right population. And maybe the others didn't restrict the studies that they looked at to this important and really the only important population to look at. Okay, so that's one thing that's different. So one of the things I found myself doing, you know, the references don't give the year, so you kind of have to also look and see, well, maybe some of these are old, and there's something new about that. Okay. So does their how many PICOS elements can you find in their aim? And which aim are you going to look at? Because there's an abstract aim.
The population.
Okay, so the population they have. Okay, critically ill. All right, good. That's P. I. And so they've described these proton pump inhibitors as one of the interventions. I guess you could think of this a couple ways. You could think of it as having two interventions or sort of two comparisons, because this is not the usual compared against a placebo. It's really a comparative effectiveness kind of study, yeah. And do they have an outcome? Pardon? The bleeding?
Yes, the prevention of HIV.
Okay. So actually they have a little less on the outcome in the text than they have in the abstract. The abstract is a little clearer because they're looking at efficacy and safety. I didn't know about safety before. So ideally you'd want to have those two aims say the same thing, but you can kind of begin to see how you can go through and kind of look at these points and keep the place here in the study, and then turn to the manuscript that's right before it, which is the Methodological Standards for the Conduct of Cochrane Intervention Reviews. And this is not an article, it's just like the checklist with the rationale and so on. But these are these standards. And so on page 1 of the standards, they have standards for formulating review questions. Okay? And they're fairly clear. They're mandatory or highly recommended. They have an item name, and that it's really pretty specific. There's no guessing about it. Here is then the standard, and here's the rationale and elaboration for the standard. Okay, so this becomes a kind of handy guide for at least thinking about all of the things you might want to do in your systematic review. Not all of them will be relevant, particularly if you're not doing a meta-analysis, but it's good for you to be aware of them, certainly when you're putting this together, and it'll make your job easier. Okay, so they want to have ensure that the review question and the outcomes address issues that are important to stakeholders. This is actually the practical thing. Are you looking at something that hospital administrators, physicians who do critical care need to know, and patients want to know? They want these objectives or aims defined in advance, and to include, they actually don't have capital PICOS, but that's obviously on their minds. And because this is intervention studies, they want to look at potential adverse effects, which was part of what we read in the abstract anyway, safety. So you can see, kind of working through this, you sort of have a little bit of a primer, at least the Cochrane's view of how to do a systematic review in this area. And then they clearly have a setting eligibility criteria on page 2 is like a whole page. There's a lot of, they have a lot to say about it, right? So what did our guys do? Now I'm going back to the manuscript. I'm looking on page 2 and I see methods, and the first thing I see is eligibility criteria, which is the first thing I should see. They pretty much laid out eligibility criteria of interest, but are they, do you think they're clear, and have they done everything they should do? And what framework did they use in the bold headings for defining their eligibility criteria? PICOS, right? Only it's types of studies, so they missed on the S. But they have laid them out. Now, remember, we said there are more things that the librarian would have been asking them when they started this. So it turns out that you have to look at the search strategy to also find out that buried in there it says no language or publication date restrictions applied. So they did tell you a little bit more about their criteria in another part of the methods section. You can see why it would help to know what stakeholders think about these criteria, because just hearing from Mike that yes, they should be looking at critically ill patients and not just a general patient population. That gives us confidence that they maybe have tackled the right types of studies and the right question to ask in this area. Okay. Yes.
What's the role of the librarian? Because you have mentioned it, I'm not sure what's the role of the...
Lovely. That's coming up. Yeah. Actually, just thinking about what I had to show you. So the librarian has, in part, helped this team define its eligibility or inclusion criteria, because if they haven't figured out some of these things, he or she has said, I need to know this, right? So that's one way the librarian has helped. Let me pull up what I have to say about searching. And let's meanwhile also look at what Masir has to say about searching, because so they're still working on criteria, page 3. They say one thing about setting up the searches in the protocol, because in the Cochrane you have to submit yeah, I think that, is this Cochrane supported? Yeah, it is. They had to define a lot of things up front in getting approval for the protocol. But then, starting on page 5, 6, and 7, they have stuff, all of those standards relate to searching, which is a lot. And that's been one of the sort of new things that has come up, as I've already said. Okay, so searching.
Something interesting is that apparently there's no mention about costs.
Oh, you mean in the
in PICOS, in the
yeah.
description. I mean, because you may have some But if it is an infinite cost, I mean,
Yeah, and so you would have liked to see a second aim, or that also says, and okay, we've weighed the effects. Now let's talk about the cost per effect. And the Cochrane does have a whole chapter on economic studies. There just aren't enough. Is usually a big problem. And it was something that the Community Preventive Services Task Force really intended to look at, and they almost never could because they really weren't either they weren't very good, I mean, they were terrible, I guess, in general, cost studies, or just was kind of ignored. So this wouldn't be really, this would be helpful in doing a guideline and making a decision, but you want more information because of this problem. What I'm not finding the slides for the next part, but I think it's going to be all right. I did a little presentation on that's in the book. It's the one that has color, and I didn't say much about searching. I really just said there are a lot of things to think about, and one is publication bias, and when you say I restricted my search to the published studies, there are authors who then say, because it's peer-reviewed, except that if you've done very many systematic reviews, you know how terrible some of the peer-reviewed stuff is, so that isn't very impressive. Cochrane would say it's always a limitation when you've restricted it only to the published literature. And don't try to make it into a great thing because there are so many problems with publication bias, and so authors don't publish, or they publish much later. Reviewers don't like them. Journals don't publish. There are all these things that kind of are problematic, and some of the so-called gray literature is very strong. And these are governmental agency reports, and particularly in low-income countries. Some of the best work is done by NGOs and is not published. And so when I tell someone who has gone through a doctoral or master's degree that their work is officially not peer-reviewed, you may laugh at that because, of course, you feel like it's been reviewed and reviewed and reviewed.
I don't have the PowerPoint version, but we have the PDF version.
It's all right, but it's in front of them.
Do you want to put it there?
No, it's fine. How can you find the gray literature? Well, this is one thing a librarian can help you do, but certainly dissertations and master's theses can be located with the University of Michigan database that you now all submit to. But there is actually, the New York Academy of Medicine has a gray literature how to find kind of website. And so there are actually quite a few resources for systematically looking at the unpublished literature, but it can be a burden and a resource cost. There are sources that help you look at conference proceedings, and the best resource that actually I've seen is particularly for middle and low-income countries. Google actually has country databases, I guess is the way to describe it. So if you want to know about HIV, some aspect of it in Thailand, and can read Thai, or make sure that you have a colleague who can, Google Thailand has a whole treasure trove of really strong NGO kind of resources in some of these areas that, as well as their fingers on the pulse of who's writing about Thailand in Lancet or some other journal. So you have quite a robust set of possibilities in the unpublished literature, so-called unpublished literature, gray literature. So what I've said and why I only put together 6 slides is just that Masir has a ton of stuff about searching. They really recommend that you not restrict by language. Actually, well, they use as many international databases as possible if you're looking at international literature. And that the one thing you would want to be sure to do, even if you're restricting your review to the published literature, is once you get all your studies that you select, look at their bibliographies for any new studies. And that's called purling, or there's various names for it, but that can really help improve the productivity of the search. Okay. So with all this stuff of looking at multiple databases and looking at bibliographies and so on, there's a huge management issue. And do you guys have EndNote for your library, or RefWorks by any chance? Which one? Okay. Our librarian has put together just great resources on how to set up a RefWorks account that it becomes the database for you to manage all the citations. So let me tell you, the first wonderful thing about the database is you searched PubMed and Medline, and they have a whole bunch of overlap. You can exclude duplicates just like that. So the management in RefWorks is really, she's really put together some good resources, which I'm glad to pass along. And it even takes you through, okay, you're going through now and you're study number 1, you're excluding for this reason. You can set it all up and just work your way through it, and it will produce the flow chart that you need to show, there were 22 zillion unduplicated citations, and I got down to, 17 studies at the bottom. It'll do that for you automatically. And it'll even do a kappa correlation between 2 different reviewers. It's really a great resource. And so, I'd be happy to make that available, because it's unmanageable to do on paper. You're just overwhelmed. And again, you remember this, librarians are always trying to get you more stuff. And so this is really important. So the state of the art now, and I can also send this as part of the package, is you describe the databases and the interfaces you used. You describe the main concepts that you looked for. This is not keywords, it's just like big picture stuff. And then what should be available from the first author, from one of you, is the search in Medline. Remember, the search has to be different for every single database. So you can save those, and then they're available. And also, inevitably, you have to update stuff. And you can easily just rerun it. You don't have to recreate it. And so Cochrane now says, okay, we want all of those things to be appendices, and do not touch them. Do not retype them or do anything, because you'll make mistakes because it's all this syntax stuff. Just reproduce it. So I think sending, those of you who want to sort of want to do this, I think using RefWorks is terrific. And even if you use EndNotes for your bibliography or something, RefWorks just is really good as a database, and it'll save you tons of time. So searching is a big deal. I'm going to, yeah, good.
Very literature, publication bias, and so on and so forth. Fine.
Yeah.
However, you have published something. I mean, you have passed some filters. I mean, of quality, presumably.
Oh.
So I know. There's a lot of stories, but there is no guarantee if you are, in general, in the great literature.
Ah.
Perhaps some governmental or whatever. But you see, still, I mean, if something has passed a peer review, at least you know that you can go back and ask things. I will guess that yes, you have some guarantees more than if you haven't published.
So. So here's, the argument in front of, publication matters. I mean, we've all had to revise and resubmit. I mean, it feels like you're in a conversation with a bunch of people sometimes who are saying, yeah, I don't like this, but if you rewrite this, it'll be okay. So it feels like a lot of quality control has gone into it. And that varies a lot over the kind of journal it is, because there is a sort of quality gradient. Yeah, and if you're senior enough and bulletproof enough, you might say, I'm only looking in good journals, and here they are. It doesn't feel like you're going to make a lot of friends that way, and your colleagues who publish in them, But I mean, that would be a reasonable thing. I know they do a good job of reviews, and I'm sticking to these journals because they're my quality control. But you don't see that very often because.
I'm not arguing anything here. Absolutely.
Yeah. But you're just saying,
yes
well,
or no. I'm just saying that even if this thing is how you weigh different studies.
Ah.
And how you weigh different publications as well, or sort of publications. And perhaps they shouldn't be weighted the same.
Ah, very good. Well, we'll get into some of that in the afternoon, but some of it is conceptual and upfront. As we are starting to, these are reporting standards that I kind of wanted to just show you for a minute. So you could decide, I just want to look at studies of a certain quality. Now, I've said reporting standards aren't the same as standards for judging the quality of a study. But you can read reporting standards, and if you look at the Consort webpage, it's a whole family of checklists and data about why this criterion has been added because it matters. I mean, we know that studies that don't have this characteristic are more subject to bias than others. And so you can use the reporting standards and this database to kind of come up with, what would be my minimum standards for certain types of studies. Because the grade people definitely say, well, a randomized controlled trial maybe trumps a quasi-experimental design unless it's a lousy RCT. And so, you know, the issue of quality is not just one design is always better than another, but it depends on other factors as well. So this is a really good kind of place to get some pretty strong ideas about good methods. For those of you in epidemiology, anybody know about STROBE already? For those of you publishing epidemiology studies, STROBE is your friend. It is a reporting standard for observational studies in epidemiology. It has lots of really authoritative definitions. You know, what is a particular type of study, and why do we say that this, what's the data that says this study characteristic is important? And this is the one that really helps you write your study up, your primary study, because it gives you examples of how to say whatever the criterion is from the published literature. So I always make the point, this is not the judgment of quality. On the other hand, it will make your study be better if you look at this before you do it. So when you're designing it, you're going to say, oh, I could, you know, I could add this safeguard. I better do it. I don't want to read it. I don't want to have to look at it after I've completed the study and now I'm doing the write-up and I didn't even know to do this. So it helps in that way. Let me make a few points here, and then I'll get to attempts that people have made over the years at doing quality scoring. So on this set of slides are suggestions for what data you might want to code to describe each of the studies in your review. Okay. Now these lists are from the Cochrane handbook, so they're more oriented toward intervention studies, but it's a nice checklist, and you can see that it overlaps with eligibility criteria. You know, some of these actually could have been your eligibility criteria, but maybe you set it broad, and now you're going to have to do more coding. But you start seeing, for example, here in methods, these are all critical issues having to do with bias. And so, but I'll kind of run through these. These are the kind of things you want to look at in each of these categories. And the one, yeah. So students think about coding every one of these studies. Let's say it's 10. That's still a lot to do. And so you find yourself trying to get finished with the coding form. And you're looking for these things, and that's all you look at. And sometimes people forget to read the studies, and they have real wisdom in the introduction and in the discussion, which is usually not what we're coding. And so I worked with a student who was looking at tuberculosis, delay in seeking treatment, and then delay in diagnosis once the person entered the clinic in Southern Africa, where almost all TB is an artifact of HIV positivity. And because she didn't read the articles for a long time, she missed a lot of discussion of how these two kind of things fit together, how clinics deal with the stigma for one, and so it has always reminded me that you do want to read the studies, you know, not just kind of go through them and pick out stuff. Okay, and the other thing is, yeah, the Cochrane lists are written for the intervention studies, but there's actually a lot of kind of interpolation that you can do because you're looking at a different kind of study. Okay. All right. So some of the resources for your code book are the standards of reporting, the Cochrane glossary. I mean, it defines many things that you're going to want to know the definition of. Other glossaries or authoritative definitions. There's certainly a lot in the economic evaluation literature. Existing code books, because now there was a study done before yours, a review. You can write to those authors and say, may I use your code book? Scope notes and databases, that's a Helena thing. But it actually helps you define some of your variables. This would be database, sort of the mesh terms and so on, and the definitions. Okay, this is hard to read, but these they're a pretty blue set of boxes sprinkled around the strobe guideline. They're the definitions of this is a cross-sectional design. This is a cohort design. What? And these are not always at hand. I mean, this is what you have to do to have a code book that's reliable and valid. So this is an example of, this is actually from a code book where we gave some definitions so that the coder has some ready and definitions of what each of these means. Like, what is a healthcare setting? Sounds like we'd all know the answer to that, but you set a coder down with a study that it maybe is a kind of home healthcare thing, and your coder is got to be guided. Is that healthcare or community or what? Okay. So this is an example of a data entry form, kind of code sheet that I'm glad to make available to you. And these are sort of made for relational databases, but because there are sets of things nested in other things. And what I mean is, for example, a small thing. It may take 3 articles to write about one study, because they have different follow-up times, they have something on the planning, and so you might have multiple study reports, single study, and you want to be clear that you've matched them up, and you understand there only one study is represented. But it can go the other way too, not so much in public health or medicine. Usually it's more in psychology, where you have maybe 3 studies in one citation. So that's this idea of sort of nesting, but this will work reasonably well on an Excel spreadsheet. So lots of stuff can go into coding. All right. Study quality. Maybe it's maybe you're going to put your trust in the best journals, maybe journals with an impact factor of something, or some other way that you can differentiate journals. But it's long been the case that people working in these areas have said, some studies are better than others. And we all know that. Are we prepared to, develop scores for studies? And so there have been a couple of major studies, one funded by ARC. There's also been some other funders who have faced off different quality coding systems against one another. I mean, there are over 30 that they could find. And the big problem is that they emphasize different types of validity. So your coding scheme really is big on internal validity and efficacy studies, and doesn't almost care about generalization at all. And yours, though, has a big emphasis on practical issues for public health and applications in medicine or dentistry. And so your items are really a lot about generalizability. So you're going to be saying, do they restrict the population to people with only one, illness and exclude people with other comorbidities? That's a negative, and it might be a positive in yours. Anyway, the upshot of this is that summary scores to identify trials of high quality is really problematic. And so where Cochrane went with this is actually kind of cool. So we talk about study quality as if we know that a flaw in a study actually caused bias. I mean, I know there's something funny about your random allocation, but I don't actually know that it was a problem. And your results shouldn't be trusted. I just know that I'm kind of suspicious. So Cochrane came to the wording that I think is much more appropriate. It's a risk of bias. We don't say we know it actually occurred, but what they also do is they don't sum these. They just lay them out. And then this happens to be this red-green kind of deal. But so it helps you look at the strengths and weaknesses of the various studies according to criteria that have been shown to matter, and many fewer have been shown to matter than we can think of based on our research classes. And so they're not summed, and they only talk about risk of bias. So this is an approach that I would recommend. You may not choose exactly these criteria, but then you could say, a study that has, I don't know, all reds, I'm going to exclude. It has too many risk factors to be taken very seriously. Or I'm going to show the best studies in a meta-analysis, let's say, and then the questionable ones, and you can look, this would then be an empiric kind of look at, do they look as if they're the same family of findings, or are they different? So that's kind of the new way of looking at this. And then the last issue, because if we think about reliability, and reliability is important, what are some of the standards in these review assessments and in Messier about having more than one reviewer, for example, choose articles? And Messier now says you've got to have 2 independent reviewers, which means for students, I always tell them that means somebody on the committee has to code, or has to do study selection. But also in doing this data collection within the studies, they also would like to see 2 independent coders, or they call it data extraction to get a sort of dental feel to it. So what would make you feel more confident that this study data extraction or study coding was both valid, or reliable and valid? Okay, so I've already named one. 2 coders working independently, and I know how they resolve disagreements. And maybe there's a kappa to say how much agreement was there. What else would make you feel better to read in a methods section about data extraction or study coding?
It's just I'm not sure what you mean by data extraction. Since I haven't made any data analysis, it might be that you get all the data from the people and you combine, or?
Oh, okay. I'm just saying, let's imagine that you're trying to describe all of your studies, and you've developed a code book with study characteristics that you want to code or extract from each study.
Okay.
And I tell you that I have a code book and I have some data extractors. Okay. What would you like to see in that paragraph that I've written about this part of my method that would make you feel more secure? That what you see in my evidence table is something you can rely on. Yes?
How about if that is done in a peer review kind of manner in which 2 separate people code the same information,
Good.
the same articles, and then get together.
But they're separate. They don't just check. It's not me checking your work and saying, oh my gosh, I'm tired. And he's usually right. No, I have to do it myself. Have to do it. Yeah, good. Good. So that'd make you feel better. What else?
Well, you just check any vested interest, any conflict.
Oh, okay. Oh, good. Conflicts of interest. They've got people who are really gunning for certain kind of articles. They don't like them. And, I know I should.
Power struggles.
Right. So let's think about things like I trained the coders, and so they all had so much training, and can they be just people you get off the street?
No, they're prepared.
Oh, they have to be themselves health professionals or student health professionals or
housewives.
Data collectors, there you go. So something about the coders and their qualifications and the training. I'm going to push us a little bit faster so that I can make sure I get us to the...
So quality control, internal quality control.
Yes. And so I say that I used a coding form that used definitions that I took from Strobe. And, so you get a sense of layers of more authoritative kinds, not just, we used to just say we study design, just like everybody would know what we're talking about. But no, it's all, we have definitions, we use the code book that had been used in Dr. Cook's famous review. So it's a little bit more like a measurement instrument that we're interested in the reliability and validity, and those kinds of characteristics make us feel more confident than who knows how we did it. And so actually, what happened in the proton pump study, they tell us what they...
Perhaps also the availability of raw data.
Okay.
Availability of raw data.
Oh, no, that's it. So I've been kind of talking about anything but the findings. But yeah, the findings are even more problematic. So they say 2 reviewers independently extracted the data. That's this term that's now become kind of state of the art. Disagreements were resolved by discussion and consensus. I don't know. Yeah, that's a little weak, but I don't know. Presumably Dr. Cook was in there arbitrating, as the judge.
What would you rather have seen?
Pardon?
What would you rather have seen?
Well, sometimes they say the big guy decided. The senior author made all of the calls. would you feel better about that? I don't know. Yeah, it's maybe a little better than the coders who are really tired and cranky and sick of coding, and who just say, "Oh, Mike, that's fine. You know, let's just call it this," and that'll save a lot of time. That would be very tempting. And so it probably is better for maybe this third big person to come in once a week and hear all the disputes and to make a decision. You know, maybe that's slightly better. And then here's this author thing. Authors were contacted for missing or unclear information. That's a big investment. It may be the only way you can actually code a particular article. And it can make, it can be an amusing, sometimes, exercise. I was once looking for some data that were part of a divorce settlement, and she got the data. So I've had some really funny times talking to authors. Or she doesn't know if it's a standard deviation or a standard error, but maybe the other guy does. Anyway, lots of funny stories. And then this proton pump review has a section on methodological quality assessment. How did we, you know, what format did we use, or what criteria did we use to decide about quality, yes or no? And so they've spent quite a bit of time on this particular aspect, and kind of less time on some of this stuff that was probably more straightforward. The kind of literature I'm looking at is usually less straightforward than this. Okay. Okay. So we've got resources for you here. I'm going to include a little paper that some of my doctoral students wrote about Equator and these standards, and because there's some really nice resources out there for you. Okay. One of the biggest limits in doing systematic review is extracting the data, the findings data. There's any number of reasons. People were fishing, and so they only report the data that turned out, and they don't tell you that they were fishing, but you can kind of tell. They do something that's totally reliant on p-values, and that's what we were doing when we were vote counting. We said, oh, no streptokinase for our patients, because, you know. But in the meta-analysis that we're looking at this afternoon, the question is, which gets the bigger effect? We don't just want to know about a p-value. We want to know about the size of the effect that they found. What is the magnitude of their finding? So the magnitude of the correlation, the magnitude of the outcome, or, you know, the prevalence estimate. So in some areas, like odds ratios and relative risk are what people report, so you're getting effect sizes. But in other literatures, certainly the one I work in most, you often don't get anything other than a p-value. This was significant, therefore it's important.
And that is very bad, because p-values are very much affected by sample sizes.
As you saw. And, but we've, for various reasons, you know, it has this kind of high, it's the high value outcome, and arguing that you have an almost significant p-value, but actually a very large effect, et cetera, is kind of uphill and hard to argue in publication. So there's I'm going to add a chapter from a really nice little book by Ellis that I guess I don't have with me right now. I can show it after lunch. That is a very nice basic primer on effect sizes and lists effect sizes for your consideration and so on. And then so part of the book is about effect sizes and making decisions about study findings based on effect sizes. And the other part is doing power analyses. So it's kind of a neat blend of the two, and I have a couple chapters that are fairly small and accessible, and I think you might really benefit from seeing. There is software that helps us do meta-analysis, but sometimes that software doesn't help us calculate effect sizes, and so we're kind of stuck. Because I'm not sure. I mean, I made a decision about this metric is the one I really like and want to, and I've been finding it. But then I find studies that don't report that metric. It's the same outcome conceptually, but it's not the same metric. And many of us don't have the biostat background to just do the algebra and say, well, you know, if I have this and this, that would be I could calculate an effect size. And so we have, my colleague Gil Ramirez did an effect size calculator, and there are some others out on the internet, but this one also is free, that helps you with some of the awkward non-matching kind of data for effect sizes. And you can play around with it, but what I thought might be the best thing is to make a...
Sorry, all of you have a folder in the desktop with a copy of the Excel file calculator, okay? So you can copy.
Yeah. Okay, but because it involves, so what you need 4 things ideally to to calculate an effect size. You need an algorithm that helps you get from reported data to a particular type of effect. And they're shown here because each of the worksheets that Gil designed is underpinned by formulas that are well accepted for calculating effect sizes. Okay, so he's done that work for us. The other thing you need, other than the article, is an inventory. And if you're reading a set of studies that has all agree on the same outcome, and they measured everything all around the same time and in the same way, then this inventory isn't so important. But I'm going to show you some examples where we had to make some decisions about which measure, and this is going to be adiposity, which measure what did everybody measure conceptually, what indicator, and how did they measure it? And we had to make some decisions, and we finally said, for the 3 examples I'll show you, we're going to look at measures of adiposity, and although we know there are better measures than BMI, we're going to take that because it's the norm, and I can represent every single study in this data set if I use BMI. These are the formulas. So here's an example of an inventory of adiposity measures for maybe, 12 studies. And I'm going to show you examples, 3 examples from that literature. But you can see we have tricep skin fold. You know, some people measured that. But look at that. Everybody measured BMI. And but we needed that spreadsheet. We also had to say at what time did they measure it. Fortunately, all these studies are pilot studies, and it was measured pretty much around the same time, a couple of months after the intervention. So we didn't have to make that decision. But there can be so many different reports of outcomes that you really have to be sure that you're making the right choices, and there's nothing like just laying it out so you can see. Okay. I'm going to run through this sort of quickly, but you'll see that you can do it yourself on the Excel calculator. Basically, we're saying, you know, a standardized mean difference makes a lot of sense for a continuous variable, and we're doing BMI. Okay, so where do we find the output for this? Okay, so this shows you one of the tables from the article, and they have the anthropomorphic measures for the different measures of adiposity. We're not too confused here because we already chose BMI. Okay, so we know we have a point estimate and a confidence interval, and we have an exact p-value. Okay. We need sample size. This is a little trial that was done after Consort came into being, and so we have numbers and a flow chart. And so this is where we're going to get our sample size. So let's just look at I want you to look at the spreadsheet. So we're going to, in the Excel calculator, there are tabs along the bottom, and so we're on the standardized mean difference level. And we enter some study data, study information. We also write in notes to say where we got the data because we won't remember it tomorrow. And, you know, it's table 3. And this we'll take the best data first. So even if you tried to fill up all the cells, it would automatically choose the optimal data if you gave it to them. Okay, so if I put in too much, it makes the choice for me. And what we get is an effect size estimate that has a correction for very small sample sizes that usually doesn't affect our studies very much, and then a standard error. And that's what you need for the Cochrane RevMan to do a meta-analysis. Okay, but if I just went to that journal article, I wouldn't have this. And I might, like a lot of authors in the very distant past used to say, well, they didn't give us the data, so I can't do anything. But we can use this article, right? Here we're comparing what if they didn't give us some of these data and they gave us the exact p-value, and that's all we had to work with. You can see the difference in the effect size estimate, 0.13, 0.14, and then the confidence interval and the standard error is the same. So it's a little less accurate, but we still get in the ballpark for that estimate. And you'll want to say, how did I calculate this? It was based on an exact p-value, for example. Okay. Harrison presents basically the same kind of issue. So I'm just going to recommend that you sort of look at this. here we had pretty much the same type of data available. And again, we looked at, I want to show you just again, we gave the, we entered the data into the spreadsheet and got our answer. We also looked at, based on an exact p-value, and we did the comparison again. Okay, so you had two fairly straightforward standardized mean difference. We're at 12, so what I think in about 5 minutes we could look at what we did with the third study, or maybe I just would say this: the third example isn't so straightforward because they talk about the incidence of obesity. There's a prevalence. There are a couple of different measures, but they're dichotomous measures. And so what the example will do is take you to the spreadsheet where you're going to calculate a log odds ratio, and create that 2x2 table from the numbers that you can find in the article. And then you will see, so you'll have this odds ratio, and you think, well, what do I do with that? I mean, doesn't fit a standardized mean difference. And actually there is a little translation program that Larry Hedges and Victor Hasselblad wrote some years back, so that you can actually go then to convert to a standardized mean difference, and now you have 3 standardized mean differences. And this little calculator helps you do that without very much difficulty. But you have, I mean, it still means that you have to have somebody doing this who has some background in biostatistics, that this work has to be checked. Because who knows where you're going to get the sample. You know, there could be things that go wrong. But this is a nice little bridge, and it also can help you calculate power analyses by converting to an effect size. So is that a good rec?